Assalamualaikum warahmatullahi wabarakatuh. I'm a medical assistant Muhammad Fikri. Today, I will do a clinical case presentation using ISBAR. ISBAR is introduction, situation, background, assessment, and recommendation. About the current situation, patient Mrs. Emily Campbell, 48 years old female, has been admitted to emergency department at 4 a.m. with a week of chest pain and shortness of breath. Currently, the patient has been stabilized and has been admitted to medical ward for observation. A little bit of patient's background. Patient claims has a niggling sharp pain on the left side chest and pain score 4 out of 10. The pain started when she sat and the pain worsened when she tried to deep breath when breathing. Patient has no fever, no cough. About the relevant past medical history, about the family history, her mom has heart attack at 76 years old. The patient lived together with her sister and a dog. Patient claimed never take any other medication other than ibuprofen and paracetamol when needed. Patient claimed never has high blood pressure or high cholesterol. Patient has Patient had undergone hysterectomy 3 weeks ago, but never has any complication related to the surgery. Patient is a smoker, 10 cigarettes a day since teenager. Patient had some heavy bleeding with menopause, but has been stopped after hysterectomy. Patient has arthritis in one of the knee. Patient allergic to the penicillin. General observation and assessment to the patient has been done. Airway is normal. Second, breathing. About the breathing, oxygen saturation pressure under room air or SpO2 is 95%. Chest clear to auscultation and respiratory rate of 20, which show a sign of tachypnea. About the circulation, heart rate is normal at 112 and at a regular rate. Blood pressure has been done on both hands. On the left, which is at 108/90, and on the right is 124/90. No peripheral edema detected. About the disability, Glasgow Coma Scale at 15, which is good. Pupils are equal and reactive to light. Temperature of the patient also normal, which is at 36.4. About the exposure, abdomen and calves are soft and non-tenderness. Bowel sound positive, and site of recent hysterectomy show a sign of healing. About the assessment, the diagnosis so far, although there is no cough, the patient maybe has pulmonary embolism as a differential diagnosis. Pulmonary embolism can be seen with symptoms shortness of breath and pleuritic chest pain that patient has during breathing. Clinical signs that show the patient has pulmonary embolism are tachypnea and tachycardia. Using Wells score to predict the likelihood of pulmonary embolism, the patient show score of 6 throughout the Wells criteria. Based on the patient past medical history, the Wells score criteria that had been seen in the patient are: first, alternative diagnosis equally or less likely than pulmonary embolism. Second, the patient heart rate more than 100. And third, immobilization of 3 days due to surgery in the previous 3 weeks. These three criteria is enough to give marks of 6 throughout the Wells score. About the investigation, to confirm the diagnosis, I have done ECG, electrocardiogram, which show a sinus tachycardia. Blood tests and troponin tests also have been done, but show unremarkable results. Chest X-ray also been done, but show unremarkable results. About the recommendation, I want to repeat the blood test again if I miss something. And based on the Wells score, CT pulmonary angiogram or CTPA will be done to confirm about the pulmonary embolism diagnosis. About the treatment, I have started pharmacological treatment on patient, which is low molecular weight heparin as a bridging therapy. When the diagnosis is confirmed, the treatment will be followed by oral anticoagulants. The duration of the treatment in this situation should be at least for 3 months to allow us to assess the risk and the benefit of continuing treatment. Vital signs of the patient should be monitored from time to time. If the condition of the patient is worsening, other treatment will be done on the patient, such as thrombolytic agents. As the conclusion, pulmonary embolism is life-threatening and must be recognized and treated in a timely manner. The diagnosis of pulmonary embolism cannot be made on examination alone. In fact, clinical examination can be absolutely normal, and unless you consider a pulmonary embolism as the cause of your patient's chest pain or shortness of breath, then you can absolutely miss it. Pulmonary embolism should always be on your list as a cause of chest pain.